Hey, this is really going to be a fast one on atelectasis. Atelectasis is not an obstructive process. It's restrictive, but it fits beautifully with asthma, especially when we talk about mucus plugging and any type of plugging, secretions in the airway. Um, it also goes along with COPD, CF, really doesn't matter, any of those obstructive diseases. So basically what you see, it's an abnormal condition. Basically, you either have a partial or total collapse, severe previously expanded alveoli, you cannot get gas exchange, your compliance is really, really bad, and unfortunately, these folks have an increased work of breathing, and we will see them using accessory muscles on occasions. For the primary atelectasis, this basically is a failure of lung expansion at birth. Primary lobules or small lungs are where the atelectasis could be limited to it, or it could be the entire lung. It's just, or segment of the lung. So we just have to watch it, okay? And it's one of the most common respiratory complications we see after surgery. Part of that has to do with the fact that these guys are really not breathing on their own. We're breathing for them, and secretions have a tendency of building up. And sometimes those secretions will start to plug the airways, and then we need to go in and work with these patients and have them take deep breaths, teach them how to cough, and teach them how to get those secretions out. So there you can see it's quite common in the primary lobules, in a lung segment, even a lung lobe. On occasions, you may see it in the entire lung. One of the Home articles actually had an entire lung that they found out of the 77-year-old who had asthma and some other issues. And basically, when they found out what was going on with her, they gave her steroids, and she responded extremely well to it. So you can put them into three categories, that atelectasis. One is reduced alveolar ventilation. We see this with pulmonary edema. We're going to talk about acute respiratory distress syndrome. When you're on a ventilator, we can cause ventilator-induced or ventilator-associated lung injuries from how we ventilate you. We have to keep an eye on what's going on with you. Smoke injuries, or another one. Another one is alveolar degassing, secondary to airway obstruction. Sounds really funny to say that, but that's basically something we call absorption atelectasis. And basically what it is that we're not replacing the gas. We have a mucus plug or something in the way. And as a result of that, once the oxygen has left the alveoli to go into the arterial blood, the lung segment or whatever collapses simply because there's no replenishment of the gas in that atelectic area. Some of the folks we see it with, you'll see with our patients who have CF, bronchiectasis, we're going to talk about those two together. Guillain-Barré, myasthenia gravis is another one too. Compression for the most part, this can be from a flail chest. We're going to talk about that. Pneumothorax, pleural diseases, anything that's larger than what you have in the airway that's going to push on the atelectic side. And remember, with atelectasis, we're going to see the lungs go towards the side with the atelectasis. So some of the other ones we can see with these are obesity, operative and post-operative supine position. These guys are not taking deep breaths. We need to get in there and have them breathe and cough for us and do things. Advanced age, because sometimes they're unable to take those deep breaths or cough. We just have to work with these folks, okay? Mechanical vent, we're going to talk about those. Malnutrition. Malnutrition has a lot of issues that people don't realize. You lose surfactant, those alveoli are going to collapse. And if they're going to collapse, they're going to be very hard to open. And if you're malnourished, you're not going to be able to do that. And there could be some free fluid in the abdominal cavity. This is called ascites, and pushing up on the lobes and the diaphragm. And if it is, then you're not going to be able to get those airways open either. And then any type of restrictive lung disorder will also cause it. And factors for retained secretions, If you don't have the cilia to remove at least 100 mLs a day, unfortunately, sometimes you have people who have cilia dyskinesia. You have other ones who have COPD, and remember the cilia decreases at that particular point. If they're dehydrated, there's no mucus being fluid being produced from the goblet cells to allow the cilia to move. If you can't cough, the cilia can't help you, unfortunately. And so if we give you just to get general anesthesia, you're out of it. If you've had surgery, when you woke up, you were probably a little dingbat because they really affects folks. Anesthesia does, and then people are in there going, cough, cough, and you're going, ah. Gastric aspiration is one. That's where we have to watch our patients. Vital signs, sort of mimicking what we've talked about, increased respiratory rate, heart rate, blood pressure. Cyanotic. Why are you cyanotic? Remember, you have to have gas exchange. You have to have oxygen somewhere. Chest findings, opposite of what we've talked about, okay? There's no hyperinflation at this point. There's consolidation. Because of the consolidation, you do have tactile focal fremitus, a dull percussion note, bronchial breath sounds, diminished breath sounds, especially in those areas where you have absorption atelectasis. There's nothing there, okay? And then you have some mucus plugging going on in other areas too that can cause this problem. You hear some crackles, and then you're also going to hear the voice sounds, okay? And here's what you get for restrictive disorders on pulmonary function testing. Different ones. Your ABGs will be affected by this too. You're working. The problem is it's not working. And then if you have widespread postoperative atelectasis, you're not breathing, and we need to wake you up and have you cough and take some deep breaths for you. What do we see with the chest x-ray? Increased densities. Okay, instead of that nice black translucence that we see with the asthma and the COPD, now it's white, okay? Lots of areas of white consolidation. Air bronchograms on occasions, elevation of the hemodiaphragm. If you're having consolidation, it's going to pull that lung area up, and that's why you're going to see those higher hemodiaphragms. And then, as we talked about, it's going to go towards the side that has the atelectasis. How do you manage it? Got to figure out what's going on. If you've got somebody who was doing well, but they had surgery and they're now sleeping, they could be snoring, whatever. Snoring not too bad. Sometimes they can take a deep breath with that. But anyways, sometimes we have to wake them up and tell them, you need to take a deep breath. You need to cough. I'm so tired. I'm so weak. We're going to teach them how to splint. It'd be great. Set them up if you can and have them, splint, hold on to a blanket or hold on to a pillow or whatever else at that particular point, and then have them cough, okay? This is not a cough. That's a whine. It's a cough. You want to hear that, okay? Excuse me. And then, in some cases, we can teach you how to do incentive spirometry. This is a hyperinflation device. It's going to make you take those deep breaths, and that's what we want you to do before and then after. And then find out, what's going on with you. We're just going to take care of you. So how do we treat all of this? Oxygen therapy, airway clearance, lung expansion, and if we need to, put you on mechanical ventilation. And that is atelectasis.